Hi, I'm Eric Prystowsky. Welcome to another segment of EP on EP. Today I have one of my go-to guys, for sure, for many years on devices, Dr. Ken Ellenbogen, who's really been a leader in our field in this whole area. He always gets mad at me because he says, I do ablations, Eric. I'm not just a device guy, but he's the professor and chair of cardiology at Virginia Commonwealth University. Ken, welcome to the program.
Thanks, Eric. It's great to be here.
So, I'm going to break this up into two parts. First, I'm going to give you a case of mine that I've been struggling with recently. I'm going to get an online consult from you. But I'm not going to let you answer yet, because I'd like you to first go into some issues with hip bundle pacing. So this is a case of mine. It's a 68-year-old gentleman with left bundle branch block and a non-ischemic dilated myopathy, who we wanted to do CRT in. So I don't do those, but one of my team went in there, and you know how the anatomy can just too bad. So you got the best vein he could get, but it wasn't ideal. Gave it a try. The patient's just not doing that well. And so we're faced now with either just not doing anything more for the patient, which I don't like, or doing an epicardial lead, or hip bundle pacing. So we're going to come back to this case at the end, but let's talk hip bundle pacing. You've been a leader in that area. Walk us through it from the view of what is it, what should the training be? Tell us about it.
It's actually sort of fascinating because the understanding that you could pace the conduction system, pace the hip bundle, was sort of figured out in the 1970s when people were doing conduction studies. And I think it was Narula and several of his colleagues were able to take a hip bundle catheter, and by advancing it a little bit, they were able to find that you could actually take patients, and this was done in animals too, had bundle branch block, and see the bundle branch block resolve. And then that observation just sort of sat there for almost 25 years, sort of very interesting. And then in around 2000, a guy named Pramod Desmukh in a small community hospital in Pennsylvania did a series of patients who had AFib and a rapid ventricular response and a cardiomyopathy. And he did hip bundle pacing using basically no specific tools. He would put up a hip bundle catheter to mark the anatomy and then go ahead and implant the lead and then do a hip bundle ablation. And he did a series of something like 15 or 18 patients. It was a series in the teens. He wasn't successful in everyone. It was about a 75 or 80% success rate. And he reported a significant improvement in patients' ejection fraction. Not a lot of long-term outcome data. And then the field went away. Nothing happened.
He didn't keep doing it?
I think he's done some in his practice, but the resurgence of interest has really been based upon tools to make this doable. When he was doing it, it was a multi-hour procedure, and no person who can put a pacemaker in 10 minutes is going to do that. So it really took the realization of two things. One is using a lead that was originally developed by Medtronic for pediatric pacing and for selective site pacing. And I remember selective site pacing was something we were really enthusiastic about in pacing. It was thought that it might have a role in preventing AFib because you could pace the intra-atrial septum. Clinical trials didn't really show a great benefit, but it was a lumenless lead. You could not put a stylet in that lead, and so people said, well, if you can't put a stylet in the lead, then you need a steerable sheath or a sheath with a preformed curve. And it turns out they developed a sheath that has a preformed curve that in 75, 80+% of patients points you towards the septum and gets you to be able to pace the conduction system. And that really, there are a couple of people who really began to do that in Europe, in the United States, and I think it's sort of taken on a following as people learn how to do it. More and more they become just enthusiastic about doing it. I think the problem with pacing has always been that you treat the bradycardia, but we know pacing the ventricle causes dysynchrony because you're not pacing through the specialized conduction system. So it's always been some trade-off. And there have been some reasonably interesting and well-done studies over the last 2 or 3 years which say that if you just look at patients who are really symptomatic after being paced for a long period of time, there aren't lots of patients, but if you carefully follow patients, and their EF, their functional capacity, you'll find that even with people who have normal ejection fractions, there's an incidence of pacemaker-induced cardiomyopathy. We don't know whether it's 3% per year or 5% per year or higher, but it's always been a trade-off. And so the trade-off is a lot less with CRT, but with His bundle pacing, you're actually physiologically pacing the heart, because what you do is you somehow recruit the His-Purkinje system. I think one of the most interesting aspects of, just in terms of the physiology of it, is that the whole concept of bundle branch block as being fixed, as being permanent, as being something that can't be overcome, is being turned on its head.
So that when I first heard about it, I thought it was a curio, to be honest. I thought, well, whatever. And I've been trying to wrestle with why it works, to be frank with you, Kenny. I mean, we back to the predestination fiber days, which I learned about, over 40 years ago. Is this, like you say, recruitment? I mean, all these different potential, I guess we don't know the actual mechanism, it just works.
Yeah, I think the idea that there are predetermined fibers that go down each bundle is the sort of the explanation that people have had in the very first paper describing this phenomena, that somehow you capture certain fascicles or fibers that you couldn't capture before. It's thought that maybe a lot of the disease in right and left bundle branch block is more proximal than we thought, and you're capturing some fibers distal to that. I think you are right. We don't really know how it works. I will tell you that there are some theories that, the tip of the lead relative to the Purkinje fibers is 1,000 times bigger, so maybe it's a source-sink mismatch.
Right. I've heard that too, yeah.
And the other thing is that there were presented actually at this meeting some studies from the group at University of Chicago where they actually put a catheter on the LV septum, sort of mapping the His-Purkinje system. And what you see is you capture the His-Purkinje system in the septum. So somehow you recruit it's pretty clear, you recruit the conduction system of the heart, whether it's, something related to a phenomenon around the electrode or the size of the electrode. Maybe it's more related to the pleomorphic nature of the His-Purkinje system.
Fascinating. So, having said all that, we'll almost get back to my patient. Are you comfortable with somebody who has complete heart block and they're going to need something from forever? Do we have enough data? I know you're a very careful guy about this. So would that be, if somebody's starting out to do this and learning, they don't have your level of expertise, would you avoid a person who is pacemaker dependent, for example?
So that's a great question. The question comes up all the time is heart block patients. Do you feel comfortable just leaving a His bundle pacemaker? I think for many people, they'll have to do 25 or 35 or 40 and get comfortable with it, but people who have been doing this for years feel pretty comfortable doing it. And in fact, I think the technique started being used in a number of centers about 7 or 8 years ago. So there are some patients who've actually come for pulse generator change. And when you do that, you can see that if you take the pulse generator out, you see the patient still has 2-to-1 heart block or complete heart block
right,
with an escape of 30 beats a minute. A wide QRS, plug in the His bundle lead to the new pulse generator, and the QRS becomes narrow again. And so there is some long-term follow-up, which we published about a year ago, about that the patients do very well with thresholds. I think, as you implied, for most hip bundle pacing, you do pay a little bit of a price. The thresholds are generally, instead of 0.5, 0.6, which might be average thresholds in the RV apex or RV outflow tract, they're more like about 1.5. So the batteries don't last as long.
Right. That's your trade-off.
But that's a trade-off for having a beautiful looking QRS. I mean, I think one of the reasons why so many people see it and start doing it is because typically when you pace the RV apex, you get a QRS of 155, 165, 170. When you start pacing and you see a QRS of 90 or 100 or 110, it makes you pretty happy. We've done some patients who have congenital complete heart block. We go out of our way if we have a patient who we think, particularly elderly patients in their 80s who have AFib and they're 120 beats a minute and just can't control their heart rate, or they're on 200 milligrams of a beta blocker and low-dose calcium channel blocker, and again, they're still fast. Pace, and they sometimes are referred to us in their 80s and their left atrium 6 centimeters. And so this is such a great thing to do for those patients because they end up with a QRS that's 90 milliseconds. And they may be in AFib, we've given up on that, but that's a good thing.
Well, you clearly are an advocate for the procedure, that's for sure. So very quickly before we have to get off the air, what do you want to do for my patient? Let's assume you have both expertises. Let's not say you're Prystowsky who's never done a hip bundle pacing. Would you go to a epicardial or would you go to a hip bundle?
So there are two things I want to tell you. I think in a patient who is healthy or even sick, I would absolutely give them the option of hip bundle pacing.
Okay.
It works about 80% of the time for right bundle branch block and about 75 to 80% of the time for left bundle branch block. And I'm acknowledging there's some conduction system disease that sure is diffuse and peripheral, but in the majority of patients it can be done in 80% of the patients, and they can end up with a relatively, you can take them from your patient who has a 158 or 160 millisecond QRS to 100 or 110. And we actually, that happens to people all the time. And we have a series of patients in press in whom we use hip bundle pacing for CRT. And a good chunk of those patients are patients who either we couldn't get an LV lead in, or like you, we could get an LV lead in, but patients were non-responders. Right. And we have case reports of patients who are complete non-responders to CRT, even with the LV lead in an excellent physiologic branch, and they completely reverse their cardiomyopathy. I will say one more thing about, you asked me who can do it, what sort of training. There's a prospective randomized clinical trial of hip bundle pacing in London, and the guy who's doing it told me he's done 100 cases, 101 cases, and 98% success. And I was like, that's pretty impressive. I said, who taught you how to do it? He said, no one. So I think it's a technique you can learn, right. Particularly an experienced implanter. There are videos on the web that show how to do it. The technique is not that hard.
So you're putting your nickel down on a hip bundle lead. We're going to take out the LV lead. We're going to go back in. We're going to put it in a hip bundle. If that doesn't work, it's one of those 20, 25%, then we take her for an epicardial.
I'm putting my quarter down that your guys are going to be able to do it.
Ken, thank you so much for joining us.